So we talked about abnormal urine bleeding. Again, understanding most of the time you'll get that's going to be the history. And there are many causes for abnormal bleeding. Structural causes, that's something that we can see on a slide. So for example, polyps, adenomyosis and hysterectomy, leiomyoma, or malignancy or hyperplasia. And then it could be something that we don't see. So that's our job to tell that we actually don't see the cause, but there are other clinical scenarios when you can have abnormal bleeding. So that's one of the clinical correlation part, which is we are doing our best, what we can, what they give us, but they also have to correlate clinically. So this is a checklist. This is what I expect people to know when they come on service. There is no time with 30, 40 biopsies a day to go over all this. But I want the sign out to be interactive. So if you guys come with this kind of knowledge already, that makes it much easier because we can talk about things. So I expect people to know what menstrual endometrium looks like, late menstrual as well. Proliferative, we talked about that. Secretory, early and late secretory. Not a lot, right? This is something you need to know because that's really, most of your biopsies are going to fit into one of these categories. Metaplasia, so this is just, again, what we talked about. And the unknowns, I recommend looking at the books because oftentimes we don't comment on metaplasia on endometrial biopsy. We just sign them out as proliferative or whatever. But some of these are more common, like tubal metaplasia. You can see it in every case pretty much. I don't really comment on it. Eosinophilic and hobnail metaplasia is there. It might be worth mentioning when there's no other finding or you see it on a polyp like that other case. IUD effect, I recommend knowing all the changes you can see in IUD. So IUD will cause metaplasia on the surface where the IUD is touching the endometrium. Most of the time squamous metaplasia. But remember, you can have chronic endometritis from IUD. You can have which organism? Actinomyces. So just again, to know, what with IUD, what changes you might see. Because oftentimes the history is not given, so you're not able to put together your findings with the history, so you need to look at the chart and, oh, she has IUD, so it makes sense to see these changes, right? So anytime you see metaplasia, the most important thing is to assess the architecture, right? Because metaplasia by itself means nothing, but once the architecture is off, glandular complexity and crowding, that becomes a different game. The more complex, the more crowded, the more likely that there is an underlying carcinoma or unsampled carcinoma. And that's our job, to communicate that to the clinician. So a carcinoma, so I'm not gonna try to say what's in the book already, but what I wanna emphasize is that, of course, there is the Lynch syndrome, which I have a little bit of more information. What I want you to guys understand that this type 1 and type 2 is very old and it's probably not really applicable anymore. I'm going to revisit because it somewhat ties into the etiology of different carcinomas of the endometrium, but the concept of type 1 and type 2 will go away because we have molecular classification for endometrial cancer, so that's probably what's coming. But it's still good to know because certain things will remain the same, but the concept probably will change. The prognosis, let's see, type 1, you guys know it's good prognosis. It's usually low grade. It's arising in a background of hyperplasia and oftentimes driven by estrogen excess. So anytime there's hyperestrogen condition, whether it's PCOS or hormone replacement or anything, the mutation pattern for type 1, again, endometrioid is different compared to the type 2. That's how you can use your stains for type 1 and type 2 to differentiate if you don't know. But again, this is probably not applicable anymore because FIGO grade 3 tumors very much overlap with type 2 tumors. So again, but I'm reviewing it because you might still hear this. And it's not, I'm not saying it's wrong, but when we look at the prognosis, it's not quite applicable anymore. Type 2 are the ones that are high grade. So when we talk high grade, we are talking serous, clear cell, triple MT, undifferentiated and dedifferentiated. They are often arising in an atrophic background, sort of true. And they often carry p53 mutation, so serous obviously is one of them. And they have adverse clinical outcome. They often present with extrauterine disease, even at the time of diagnosis, even when it looks like it's low stage. So this is the WHO. It's not that new anymore, 5 years old. So I recommend just knowing the entities. There is some stuff here at the bottom you'll never see, or you most likely won't see, but you need to know these. I guess I was wrong on the unknowns. It's 50%, not 90. That's breast. Never mind. EIC is a separate entity now, so make sure that you first of all, you need to know what EIC is, and I'm going to tell you, but no, that's a separate entity. This is the most important thing here. The 4th-tier grading of endometrial hyperplasia is gone. This is what we are using here. If you are not familiar with the concept of EIN, there is a nice review article on the shared drive in the GYN folder. Read it. It's very, you can digest it very easy. It's just review with the examples. Very, very helpful. But we are using EIN now, and in any settings when EIN criteria are not met, but there's hyperplasia, you can say endometrial hyperplasia. And you don't really even have to say without atypia because it's just endometrial hyperplasia. So where the diagnostic workup of endometrial cancer, which we kind of already talked about a little bit about it, the specimen you will get most likely is a biopsy reportage. The amount of tissue will be most likely different, not always. We heavily rely on the morphology on low power. So glandular crowding is your key feature for endometrioid for sure. Cytology is going to be something that will help you both for endometrioid, but for other serous and clear cell as well. So it's kind of a low power and then a high power assessment. And then in your head, you need to put it together whether the criteria you're seeing is sufficient for the diagnosis of carcinoma. Once you think it's carcinoma, the next we have to figure out what kind. The reason we have to give them as much information as we can, because there is managerial differences between endometrioid, especially low grade, versus high grade. The staging is different. It's a much bigger procedure for serous, omentectomy, lymph nodes, all that stuff. Versus endometrioid, they might just do lymph nodes. Omentum is usually not taken out. This is your key stains, so it's not a lot, 8, 7, that we routinely apply. It's also, there is a share drive with a handout of commonly used stains in gynecologic pathology. I'm going to update everything this week one more time, but these are the stains you need to know. And honestly, out of these stains, P10 is really not routinely used. HNF is not as good as an napsin, so I would want a napsin, and ERPR is used really for more for prognostic purposes. You can, of course, use it for differentiating serous and endometrioid, but it's not always clear cut, so you can have some staining in the serous. Ancillary testing. I think all you have to remember for this one is that we routinely do ERPR on all carcinomas of the endometrium and MSI as well. So all of them, regardless of what kind of cancer. So this makes it easy to remember. Like ERPR, MSI. The PDL one is only if requested. And then the second round, if the MMR comes back unstable, then MLH hypermethylation testing is done. It's a send-out test. But that I would like you to know that that's the next step, but you don't need to pre-order or anything like that. You can review the MSI together and then take it from there. So this is, again, the quick summary of EIC and EIN. And even the clinicians get confused. So they're gonna call you and ask you like, okay, what do I do next? So the two are very different. EIN is endometrioid. It's a precursor of endometrioid adenocarcinoma. There is certain criteria. It has to meet both morphologic and cytologic criteria, and it has a size cutoff of how much? 1 millimeter. They are often ERPR positive, obviously. So P10 is a stain that we have here. It is not recommended to use a diagnosis of EIN. So you don't diagnose EIN and do a P10. You diagnose EIN on H&E because P10 is only lost in about 60%. It's a difficult stain to interpret because you're looking for negative stains, right? So the background will your positive control. But other things can have loss of P10. So you cannot rely on P10 alone. You rely on your H&E. And then other P53 on P16 are not positive. EIC is a different game. It is a precursor of serous carcinoma. It is a carcinoma. Think of it as in situ on the surface or a few glands. Very challenging diagnosis with carotting or a biopsy. Your key stains are, we already went already through the stains, P53, Ki67, because oftentimes they're postmenopausal. You would not expect mitotic activity in older women. So you want to tap into your MIB1 just to kind of help you. It will be helpful to differentiate surface metaplasia from EIC as well. Important because hysterectomy is the only way to proceed, and sometimes there is disease in the uterus and the lymph nodes, even in EIC. The most common setting you see EIC is surface of a polyp. So just, go for the X, take your time, look for nucleoli, look for atypical mitosis, because it's a big deal when you catch it very early for the patient. Here's an example. So can somebody get the other line too? Thank you, Brian. On the left is the biopsy. So the clue is often on high power that the nuclei are big and dark and there's common nucleoli. Something that should, and don't be shy ordering stains because, that might give you the answer. And then this is the resection. So obviously what you see here is actually the scraping of these little surface glands. So marked cytologic atypia, mitotic activity, hypochromasia, pleomorphism, all that stuff. So these are your stains here. So again, we use for the P53, that's what we need to see. We can see a null type. Null type means no staining whatsoever in the nuclei. That also counts. It's going to be a small subset. And then C is showing you the wild type staining pattern, which is a few nuclei here and there. So when you report P53, we say positive, negative in parentheses, null type, or wild type, not positive, negative, because that's confusing. P16 looks like diffuse and strong. E is endometrioid. This is what endometrioid looks like, mosaic pattern, not all the nuclei are staining, as opposed to that, so nice contrast there. So what happens when you have excess estrogen, whether it's endogenous or exogenous, there is a population of endometrial glands that will undergo mutations and then outgrow and become clonal. That's EIM. I have, well, I don't have a lot of examples, but it will come on the H&E to you as a cluster of cytologically abnormal, distinct glands. Abnormal does not mean atypical. It just looks different than the background. Your key will be to compare those glands with the background glands. And they look crowded, and that it's about a millimeter, at least a millimeter focus. Not that easy, but some things that can help is levels sometimes. If you level and the block, maybe the focus is bigger, it's more obvious, or actually it might give you what's going on. Maybe you're looking at a polyp. EI and a polyp is a different game. Usually you don't call it a polyp unless you're very, very convinced. And then eventually these clones undergoes further mutations and become carcinoma. So this is the endometrioid pathway. So here's an example, adenocarcinoma, just like you guys saw it earlier. Complex cribriform, maze-like pattern. Cytologic atypia is not that striking. So you saw some that were pseudostratified. These are more round. So again, you see so much spectrum within one case, but it's still, if you apply your criteria, you'll get to the carcinoma, no problem. Here's P10. Again, don't routinely use it. It can be helpful in certain scenarios, but we are looking for P10 loss in the abnormal glands, and the stroma in the background is staining. This, I want to just touch quickly on the mixed type. So mixed is, don't use mixed endometrial carcinoma when you can't figure out what it is, because that's not a mixed. Mixed has to have two distinct components, and you have to actually be able to recognize them on H&E and with stains. And there has to be like a clear cut. This is one type, and then the next field shows this. So it's not when it's jumbled up, and it's not when you can figure it out or your stains are inconclusive. That is not a mixed carcinoma. Really, when it comes to play is when you have endometrioid low grade and potentially a high grade second component that will actually define the prognosis for the patient. That's when it really is important. A second clear cell, a second serous or something. Here's an example. This is a polyp. This is a real case. On the left, that left, is a serous carcinoma, and this looks very distinct. You can almost draw a line on high power. So again, I can see the line right here. This is clear cell, that is a serous. I have the stains, but I couldn't find the image. So this is a nice example of mixed serous and clear cell. Again, very distinct. It's a very small subset of endometrial carcinomas. Again, only important when you have a serous or a second high-grade component. This is high power again. You can really kind of see the difference here and here. Okay, growth. This is quick review. First years and whoever else hasn't been on GYN for a long time. So remember, we bivalve the uterus after inking. So we serially section the endometrium and the myometrium all the way as far as we can go into the serosa. And then if there's a mass, the description is very important where the mass is. And then if it's a large mass and there is a proven history of carcinoma on a biopsy, what you want to give me is actually the deepest point of invasion, if you can appreciate it on the gross. If the polyp is smaller and there's no history, just put through the whole polyp. I'm happy to look at it rather than have to go back. It's important to assess what's going on down here. So we have this large polypoid mass growing down the endocervical canal because cervical invasion will alter the stage. So what you want to get correctly is, so this one just growing down but not invading. So we need to assess lower segment and cervix. Oftentimes you are able to cut a section like this. So give me cervix and lower segment together and bisect it. That will help because then I can put the two slides together and see where is lower segment and where is cervix. But cervical involvement is very important for staging because it will change the stage. So when you rotate on GYN and you fill out several synoptics, it becomes automatic to understand what are the sections that are needed for staging and why we take them. That's the hard part of being a PGY1, that you don't understand why we do things quite yet. But as time progresses and then you're able to look at a lot of synoptics and go to tumor board, you realize I'm doing these sections for every section should have a purpose, right? So ideally, so you in the cervix, we want to look at cervical stromal invasion that will change the stage. Same thing on serosa, same thing on adnexa. So what we do, you guys know this very well. So we take the sections from lower segment and the cervix. We look for deepest myoinvasion in the myometrial section, and we put a nice decent size section in the cassette, ink, endometrium. If it doesn't fit, you can just indicate this is the deepest point of invasion, it's bisected, and it's an A4 and 5 or something like that. So I know that these are consecutive sections or one bisected slice. For the myoinvasion, we need to know the connection between the two sections. So this is just a quick thing about this. There was a survey sent out for all the GYN pathologists by the International Society of GYN Path. And this is what people consistently report. But they're variable reporting on a lot of things, like whether the adnexa are submitted entirely or the residual fat from the lymph nodes and these things. So for us here, what you need to know is we submit all the adnexa. It's in the manual. So if it's a cancer case, all the adnexa need to go through. The residual fat, yes, because there are sometimes smaller lymph nodes. And the omentum, it's your judgment. So if you feel something, submit it. If it's a big mass in the omentum, I need the size grossly and 2 or 3 sections. It's all done. If it's post-treatment, it becomes a bit more difficult because fat necrosis and fibrosis. So we sample diligently, it's okay. The ink serosa here for those reasons. Sometimes the entire endomyometrial thickness will not fit in one cassette, so I need to see the ink. And I, of course, it's good to look at serosal involvement, so you know that ink represents serosa, or you have a full section and that's not stuff. So what we report, again, this comes when you fill out a lot of synoptics and you understand what needs to be in the report. But obviously, we report histologic type, tumor size, grade, myoinvasion, LVI, cervical involvement. We give a FIGO stage at the end. And on cases when there's grossly nothing in the endometrium or a history of EIN, we submit the whole endometrium. I mean, obviously, if you don't see anything and the uterus was taken out for a precancerous lesion, the whole endometrium has to go through. It usually fits in a few cassettes. You don't have to do full sections. And the fimbria, so I started to see them in a moment, but make sure that you don't jam a lot of stuff in the cassette, like an entire fimbria should not go in one cassette. So, you know, it's better to submit more cassettes than put a lot of tissue in and then we can, because it all gets jumbled up, and then if you do stains, then the stains don't get to the spot I want and that stuff. Okay, so we talked a little bit about FIGO grading. So you remember the solid growth is the one that determines the FIGO grade. whether it's endometrial or ovarian primary, and 5% cutoff on a biopsy can be pretty tricky because maybe on the resection it's not like that. So I stay conservative. So if you see a small focus of solid, it may still be a FIGO 1 on the resection, so it's not necessary to go very aggressive to FIGO 2. You will see a lot of about bumping up the FIGO grade based on cytology. I recommend cytologic atypia to the degree that you would entertain serous, not just a little bit and on 40x and you're like not sure, but it's something that catches your eye and it's relatively diffuse and it's very easy to appreciate on low power. So I wanted to tell you guys this, that in the future, probably near future, they're going to get rid of the 3-tier system and it's going to be 2-tier, and it's going to be one low grade and high grade. So these are just examples of grade 1 we saw today, grade 2 more solid, 5 to 50, and then grade 3 would be more than 50% solid. So what they are trying to do, and this is from this paper, that they're going to lump together 1 and 2 and call it low grade, and 3 will be high grade. Of course, the inter-observer variability and the reproducible is much better. It's a 2-tier system, but really for managerial purpose, it's actually the myoinvasion that determines what happens to the patient. On a biopsy, oftentimes people 1, 2, 3, but the frozen comes and they want to know myoinvasion, and that will determine what happens with the staging. And the same thing for a neoadjuvant or adjuvant, because 1 and 2 is treated, no treatment, versus 3 is treated with chemo after the surgery. They say that it's really going to only come into play when they're trying to do fertility sparing treatment. So patient who is young wants to keep the uterus, they might ask you to distinguish 1 and 2, and then they give progesterone if it's a 1 to keep the uterus, let the carcinoma resolve, and then move forward with the pregnancy in the future. So we'll see. I think it's kind of cool. This is just what again, this is maybe a little bit more than what you guys need to know, at least the first years. But myoinvasion is not that easy to assess because there is no line between the endometrium and myometrium. It's not there's a basement membrane or something. So, and it's very irregular. So expect significant disagreement, 30%, between 2 pathologists. The most important for you is that if it's less than 50%, usually no further treatment is needed. So if you are between, one calls it a 2 millimeter, the next person calls it a 3 millimeter, that's okay. It comes into play when it's like, is it more than 50% or something that would alter the stage and the management. There are certain invasive patterns that will be very challenging to tell how deep the tumor goes into the myometrium. One is the mouth pattern. I'll show you the picture in a moment. And cervical involvement. So we are heavily relying on you as a grosser to give me the best section where you think it's going to the cervix, because it's not that easy to tell whether it's cervical invasion or lower segment. So these are the patterns of invasion. So this is here. It's a non-myoinvasive tumor. I can draw this line around here. Oftentimes there are little benign glands at the bottom that tells you that it's not breaking through the endometrium into the myometrium. This is the classical invasive pattern here. And this is in adenomyosis. So you have a little bit of stroma here. Adenomyosis is colonized by the tumor, but it doesn't mean it's invasive. Very difficult to tell the difference. Here is a nice infiltrative pattern. This is probably the easiest. Here's the mouth. So mouth stands for microcystic, elongated, and fragmented. If you come on service and you tell me this, you're golden already, because it's very challenging to tell that there are actually tumor cells here. Some of it looks like LVI, some of it looks like just kind of cyst, but there is tumor in the middle. So your main differential diagnosis is lymphovascular invasion versus true myoinvasion, which again will change the management and the stage. Mouth is a you can do a stain, you can do keratin, right? If the keratin highlights the tumor cells, you know it's true invasion. And you can do the cocktail, the D240, A13, because these are not endothelial cells, just cystically dilated tumor. But so if this is really deep, it could be a deep myoinvasion, or it could be just lymphovascular invasion. So we'll change the business for the stage and the management. Again, just to kind of know it exists. Probably, I mean, it's in the books, but it's not something that might be in Rosai or the regular books. It might be a little bit more GYN-oriented textbook. Cervical stroma, again, heavily relying on the grosser. And the cervical glandular involvement only when the tumor grows down the canal and colonizes the glands. That doesn't count. You have to make sure that it's truly invading the stroma, like here. So here's squamous, here's the tumor. So that will count. It's very important to, if you designate the section as cervix lower segment, to tell me, because there is no line between lower segment and cervix. Like, it's not like, oh, we crossed this line, so I know we're in the cervix. I heavily rely on what I see the benign glands adjacent and the squamous and all that stuff. So we report depth of invasion here, and this is your true margin. So if somebody asks you what's a true margin in hysterectomy, it's actually the pericervical soft tissue margin if paramecia are not taken out. So that's your true margin that the clinician actually wants to know the distance. So alter brachytherapy treatment decisions. Next one, just quickly. So it bumps up the stage significantly. So if you have a little my invasion, it's a 1A. If it's in the anexa, it's a 3A. So it's a huge deal. So that's why we submit the whole thing. Make sure that what you're seeing is not just LVI, because that doesn't count. Free-floating tumor in the fallopian tube is very common. That also doesn't count. So for upstaging, you want to see tumor in the ovarian stroma or in the fallopian tube wall before you bump it up to 3A. Sometimes you can get synchronous tumors. That can be very difficult, but we'll figure it out together. I can't really spend the time talking about it now, but that can be also very challenging. So here's a CFIM. It's in the manual, so make sure you understand how the tubes are submitted. Again, take as much cassettes as many as you need, rather than jam the entire tube in one cassette or the fimbria. It's the purpose of this is that we are able to assess as much surface of the epithelium, whether it's the lumen or the fimbria, as possible to make sure that there is no serious precursor lesion. Sometimes it also gives you the clue of the primary side. If you have a ovarian tumor, most of them are coming from the fimbria if they're high grade. Lymph nodes, I don't want to spend a lot of time because we are not doing sentinel lymph nodes here. Grady does. So just to know that there is sentinel lymph node protocol now, which is recommended. And it kind of looks like this. This is two institutions that do it, Memorial and MD Anderson. The bottom line is that they keep unstained in between, and they stain them up with keratin if they're all negative, as opposed to if it's positive, you call it a day. If it's not, you do multiple sections and then do a few H&Es in between and the keratin to identify micrometastasis. Of course, the beauty is that isolated tumors, they don't know what to do with that information yet, but if that's requested, they're probably going to implement the protocol here, but it's kind of like the breast. We don't know what it means. Okay, so and then, as I said, ERPR, MSI for all tumors now routinely. For Lynch, I want to skip this because I want to get to the test or the quiz. So this is the protocol we do. We do 4 markers if possible. And then if MLH1 loss is identified, so first we put a report out based on the IHC. And then on second round, if MLH1 is lost, then we order hypermethylation testing. It's a send out. It's in COPAD. And then based on that, the decision is whether it's a sporadic or germline testing is needed. That's up to the clinician. So our job is kind of ends here. We report the hypermethylation test results, and then the clinician decides whether germline testing is needed or not. So this is what it looks like if it's all retained. Nuclear staining. When you have loss, you have loss on the top, so MLH1 and PMS2. Your background is stromal cells, lymphocytes are your internal control. So there are some characteristic features of the Lynch-associated tumors. They're often in lower segment. They're often high grade. They show a lot of lymphocytic infiltrate. But we routinely do it on all of them. We didn't want the pathologist to have to decide when to do it and what not. The consensus was that all 4 hospitals do it on all cases, and that way it's nothing falls through the cracks. Okay. Oh, for EIN quickly. So we do for EIN we do ERPR now because some patients might be managed conservatively. And then also, one of the clinicians wants to do MSI on EIN too. I mean, you're going to pick up like, a couple cases, but we do as much as we can. Mind you, these foci are usually very small, so it's really hard to interpret 16s on this little tiny focus. Okay. We have 15 minutes or so. So easy stuff. Picture, question, multiple choice, and then at the end, and then I have the topic that the question is testing on for you to. I can put this on the share drive, and then you guys can read about it and revisit the questions. Okay, so 70 endometrial biopsy. This is what it looks like. And you have to trust me, these are representative pictures. So on H&E, what do you guys favor? And I go back. Anybody? Carcinoma, cool, okay, agree. So now what do? You can't just find it as carcinoma, right? I can go, you want me to go back to H&E? B. Okay, let me point, and I want to say, I see this, this. So what's the answer? Napsin. So it's a clear cell carcinoma again. I'm trying to I think every time I do unknowns, I do a clear cell carcinoma. But it doesn't look like serous because serous is so juicy and blue and basophilic that usually high grade that it's usually not a problem also. It's too much for any kind of other entity that was listed here. Don't forget your endocervix, it can really fool you, but then the answer is Napsin. So clear cell carcinoma, IHC and morphology. 80-year-old with ascites and a month of 80. The H&E diagnosis on her endometrial biopsy was high-grade serous carcinoma. This is the biopsy from the omentum. I show the stain. The question is, what do you think this stain is?
What was her original diagnosis?
Serous. C. So this is testing you on, you need to, when you order a stain, you need to know where the stain is supposed to be staining because you want to know, you want to make sure your stain is working, right? You don't want to misinterpret things, especially when it's cytoplasmic, it can be kind of dirty and the background is high. Nuclear stains are always much better, much more reliable. So out of these stains, ER would not work because it's so much ER for a high grade that it probably would not be my top choice. Everything else is not a nuclear or not a nuclear only. Ovarian mass, 60-year-old. One, it's two pictures. One, two. Okay, I'm gonna go back because the question is gonna ask you about cytomorphologic features. One, ovarian mass, 60. Two. So what does the picture show? Germ cell tumor?
Yeah.
No, okay, good. So what is it showing? Carcinoma. And we are in the ovary, right? So in the ovary, when you're dealing with a carcinoma, you have to know what kind of histologic subtypes of carcinomas you can get in the ovary. There is one thing that's different between the ovarian and the endometrial. Besides, I'm not talking borderline business, but for the serous subtype, endometrium always high grade. You don't even have to say high grade. You just got serous carcinoma. In the ovary, we have low and high grade. How do you differentiate the two?
High grade is P16.
Yeah, but this you need to answer this. Was the architecture help? No, that's most likely going papillary. The nucleoli, okay, I didn't put macronuclei on purpose because that would be, so nucleoli you can have in both. One's going to be higher than the other. NC ratio, I don't think is that helpful. So mitotic activity, if low-grade series does not have a lot of mitotic activity, usually 2 to 3 per 10. The high grade is going to be like through the roof. So that's why when you tap into your immunos, you're going to do P53 and P16, but MIB is going to be one of your stains and ERPR as well. Don't forget about low grade in the ovary. It's not all high grade. Okay, 33, history of 501, and she's treated with Provera. So meaning they didn't take the uterus, they gave her high dose progesterone, and she's undergoing 3 months interval biopsies to make sure if the carcinoma resolved or not. There's 2 pictures. One, and this is not, I don't expect the first year to know this, so, but if you're a good test taker, you can probably figure it out. So 1 and 2.
B.
D as dog or B? D as dog. Yes. So this is more a little bit advanced, but there are a couple of review articles on treated endometrial cancer with progesterone, the changes. The take-home point is mitotic activity will not be present because progesterone shuts down the mitosis in the endometrium. And second, cytologic atypia will not be present either. So you're truly relying on the complexity of the glands. And always, if you can pull the prior to compare, to see like what it started, and then the interval biopsies, that's a good pathologist, that's our homework, that's what we do to make sure we can comment on whether she has still residual or looks less worrisome than the prior or whatever. Metaplastic changes, this is a nice field here, are one of the features of progesterone effect or progestin effect. Eosinophilia and cytoplasmic mucin are very common in treated endometrial cancer. So don't be surprised if it looks very pink and whatnot. Cells tend to be more rounded. No mitosis, no atypia. Totally relying on the complexity. Back-to-back glands, maze-like pattern, fluidiform. Yes, residual adenocarcinoma. Endometrial biopsy. And this is, it's a carcinoma, and it's a high power view. The question is, what are these changes? Like it's cleared out. So what do you guys think this clearing represents? We talked about clear cytoplasm. Clearing of the cytoplasm can be mucin, can be glycogen, can be other things, secretory change. B is correct. And what I'm trying to kind of get to this, clear cell carcinoma would not be an option here because the cells are very monotonous looking and low grade cytology. It can be, serous carcinoma is also not an option, which also have kind of clear cytoplasm because again, the cytology doesn't quite get to the high grade. So you're kind of left with endometrioid, and endometrioid can do this. It can be very patchy, and then you're gonna freak out and do your stains because you think you're dealing with a clear cell, but make sure the cytology is, if the cytology is bland and low grade, it's probably just glycogenation of the nuclei. It can be very patchy, it's very common. So don't get distracted by that, potentially entertaining like a second component. And then, does anybody know what glassy cell is? Cervix, yeah, it's adenosquamous, right? I had to throw in something weird, so because otherwise it's not a good question, right? Oops. Pelvic mass, 49-year-old, and this is a core biopsy, which we're not gonna see more often, but so one is low power, core biopsy, 49 pelvic mass, and the second is a high power. So let's keep it at low power because, so it's kind of all looks like this. So What do you guys think? You have to have a differential before you start doing stains. And you have a core, so you can do 25 stains.
Unusual stress.
Endometrial stroma sarcoma. And so look at this. If you were to see this in the endometrium with some glands, it would look like normal endometrium, normal endometrial stroma. The vessels are very cool. This the spiral vessels. The tumor actually maintains that. So it's these little vessels, and the cells are kind of whirling around it. There is no thick vessels. Mitotic activity will not really help you. On high power, they're very monotonous looking. So we are doing the pelvic mass. Of course, this is kind of made up history because in real life, most likely will not be like that. But just looks different. The perinuclear vacuoles and the more longer fascicular growth pattern. Leiomyoma. What are the vessels in a smooth muscle tumor compared to the ESS or a stromal tumor? Larger and thick, as opposed to small and delicate, and the cells are not whirling. The smooth muscle tumors tend to have fascicles. This one is kind of just jumbled up, more like storiform kind of pattern. Cellular fibroma can be very difficult. That's when your stains might come into play. With the pelvic mass, you have probably a higher chance of a cellular fibroma than ESS, but of course, imaging will help you, and of course your stains. And the granulosa solid pattern can be pretty difficult too, because the cells are pretty bland, so you may not, the cytology is a little bit different for granulosa, but you may not be able to appreciate. So ESS, morphology, I think there's two more only. 78 with hysterectomy. So this is section from the endomyometrium, myometrium. This is the higher power of this focus. So this entity, there are some prognostic findings or histology findings we have to report that might alter the prognosis. Not like the prognosis is not bad already, but we are supposed to report it. Anybody knows? You have to kind of know the diagnosis first. Not that hard. We have this, we have this. This is the high power. What's the diagnosis? Triple MT, so carcinosarcoma. So carcinosarcoma, by definition, has two components, carcinomatous and the sarcomatous. They are actually epithelial tumors. And the epithelial component is always high grade, endometrioid, serous, clear cell, whatever. Sarcomatous component can be various things, homologous and heterologous. The mitotic index is going to be high. That doesn't alter anything, but heterologous differentiation, meaning what are the more common ones? Rhabdo, chondroid, osteoid, yeah. Those we comment on. They tend to do worse. We also comment on sarcomatous overgrowth. And the RPR status will not change.
There was a question in the chat.
Oh, how do I go there?
Yeah, cursor over the green bar.
Here?
And go there more.
More? I see.
Chat.
So, the question is on a biopsy. So, because I call it a pelvic mass on purpose, I assume it's like outside of the uterus, but of course you can't tell the difference between low-grade endometrial stroma sarcoma and stromal nodule. So you have to be very careful to know where the lesion exactly is. And if you're not sure, especially in a carotid, you don't commit. You call it endometrial stromal neoplasm or C-comment. Of course, in a carotid, you probably won't even go that far because you don't want them to take the uterus out right away. You give them the differential. So endometrial stromal proliferation, C-comment findings may represent. You have to be very careful. Of course, I put purposely a pelvic mass, which still could be in the uterus, right? So, good question. Okay, how do I just close this?
Yeah, it's fine.
Okay, and then. Oh, so we're gonna skip this. This is secretory. 77 endometrial polyp. Kind of ties in with the unknowns. It's a juicy polyp for a 77-year-old, right? the question is, based on this, just looking at this on intermediate power, what would you think about? You have to think about before you can do anything further, right?
Okay.
Brian and Sam are, what, you guys want to say something? They are just like along for the ride.
The lines of all look at the page as well.
Metaplasia? I think, to my eye, this is too much papillary proliferation towards the glandular surfaces here and this stuff here. I think I would be worried that we are dealing with some sort of preneoplastic process, especially a 77-year-old. I don't care that it's a polyp, but she's old. Her polyp should be kind of atrophic. So I would work this case up. Papillary hyperplasia is it's kind of a cool entity. It exists. It's real, but it wouldn't look like this. It would be true papillary, oftentimes mucinous, and I would not want to see it in an old woman, regardless. So normal changes in an old patient with this polyp, never dismiss anything as normal unless you do your workup. So.
So how would you name the preneoplastic change? Would you call it EIN?
Yeah, so the reason I couldn't put neoplastic because I wanted to kind of refer to EIC and EIN under lumping it in one term. So preneoplastic is really, because on H&E your stains would confirm that it's neoplastic, but on H&E it's your impression that it could be, preneoplastic. I didn't know how to word it. I'm not good at this multiple choice. But the point is that it should trigger for the workup, right? And I try to do a low power because it's a low power impression that something is off here with this proliferation towards lumen. And at the end of the day, it might turn out to be nothing, but you're obligated to do your stains to make sure. Okay, last one, I think. I'm pretty sure it's last one. 28, ovarian mass. I think one picture only. Okay, so this is hard. This is for so this is again, 28. She has some symptoms, and this is the tumor. You have to know really what this is before you can answer this. The answer kind of gives away what category we are looking at. But there's you have to make your observations. Anybody? But does anybody want to describe this quick?
Yeah, make sure tubules kind of in areas more solid sheets and interspersed, maybe some of these eosinophil cells.
Yeah, so the hard part about these tumors, when they become less and less differentiated, this is certainly lighting. The lighting cell component can be very subtle. It's very hard to appreciate. Remember what to look for. Lighting cells look like lighting cells no matter how many there are, except it might be hard to see them. But they are these eosinophilic cells with a granular cytoplasm. They are kind of percolating through these tubules. And the other component is the Sertoli. And the thing people forget is the well-differentiated is easy because both components are very easy to see. But as it becomes less and less differentiated, intermediate and full differentiated, there's less lighting cells, and the Sertoli cells are not forming the tubules. They're becoming more like solid and sheet-like. So the prognosis will, because the grading is determined by the Sertoli component, the prognosis will be determined by the Sertoli component differentiation. You guys, these are really cool tumors. You can have heterologous differentiation. One is GI epithelium, most common. I have a recut of a rhabdomyoblastic differentiation, so you can have really wild stuff. The trivia on these tumors, the poorly differentiated ones, the patient often carries DICER1 mutation, germline, so patient needs to be tested. And they're just rare and very interesting tumors. The hormonal symptoms, may or may not be present. And I think that's it. So 5 minutes over, not bad. Any questions? when you come on service, check the shared drive. I try to update things so that, and always come anytime you have an interesting case to show or consult. And if you want to get reading advice or, what to read, what books to, if you want to do multiple choice questions, what books to buy, and whatever on the GYN service, whatever you guys need, review articles or whatever, small projects, whatever you want to do. Organize my teaching set, welcome to come. It's a chaos right now, but I'm happy to share. Okay, cool.